So, because I don't want, people like sometimes, their kids are crying or whatever in the back. Right. And then you hit share. So the meeting's already recorded now. And then when you do share, system settings. Perfectly on your phone. That if I'm talking, that
Somebody said they did not cover somebody's surgery and came and shot this. Yeah, I can see your slide.
can you see me? Do I pop up?
I can hear you and see you.
You can hear me on your phone?
Yeah, I can see you like this from a side.
And then do there oh, you can hear me on your things. Oh, that's perfect. That's good. All right, we're in business. I'm telling you, it's so much easier to do it with this
Yeah, that's what I get them down because I don't connect with you now.
I'm telling you, we've had outside speakers come and
Something.
we've had outside speakers come and it's been like embarrassing.
Applying for tenure or just the professor?
Just regular. Yeah.
You can apply for tenure later, even after the professor, I think.
Yeah, I don't think it really matters.
It doesn't matter for us.
I wouldn't
employed by SSM now.
Yeah.
And we're not employed by university. What does it mean tenure? I don't know.
It doesn't mean
You
anything.
get fired from here, but you still have an appointment in medical school.
But why, tenure used to have some significance when, like academics are researching controversial ideas, or they're publishing controversial things, where like, freedom of speech really matters.
Or gun research.
I don't know, whatever it is. It's like a lot of sociological stuff, for people writing controversial books. But that it used to matter that your tenure would be a form of protection against, willy-nilly firing with that academic practice. But for us, for a person who's a critical care intensivist or an anesthesiologist, but I don't know. Maybe there's something I know.
Especially now that we're not employed by SLU anyway. Like we're employed by SSM. There's no tenure in SSM. You're probably getting tenure for your School of Medicine appointment, which you're not employed by SSM.
Yeah.
Yeah, I applied for associate last year. I never said anything until the final. Exactly. That's it, that's the problem, so that's fine. But reject someone that was approved by the chair.
If you want to listen to Deanna's lecture, I can put on headphones, so. Are you going to listen to that in here? Yeah, okay. Then I'll put on headphones. Yep. Yeah.
Yeah, they increase my price. Yeah, so you don't get the bump just from assistant to associate, you get. The new associate is getting. Yeah. But technically, you're applying cards, right? Before twenty. Yeah, they're all like.
Last I checked, they're on 10.
Oh, then that's it. Right. Yeah.
It isn't funny, I think, like, it is bad. Yeah, actually, that's close. Yeah, we can, they're wondering.
What's the worst thing? You can really do it, you know that. The problem is when you get rejected in the next year. That either way to talk.
You have to have, it's harder because you have to get more stuff than your initial application. That's what I was told. I don't know.
So that's a myth, actually. That's a myth,
Yeah, that's what I was.
because that used to be what people thought.
Yeah.
Gee, that's not, that's actually the.
Yeah. Because some people tell me, oh, they're gonna say we rejected you based on that CD. If you haven't had much stuff added in a year.
Well, here's where you keep the same CD and just keep doing the same thing. It's the definition of sustained commitment to sustained. Continued.
Yeah.
That is simply like that word. It's good old leadership, make clear. So someone that's like 1 year talking. 2 years. 3 years. Yeah. That'll change. Their CD.
It was thought you as instructor, take super assistant associate.
My friend has 2 MA experience. She's the director of methodology. She's 2 MA experience. She's 120. She just needed an instruction to assist.
Yeah, that's how they are.
Should we get started?
See how many are.
There, I see 10 people. Do I pop up on your teams? When it shows up?
Oh, you know, he's not like for kind of the next year, like. So they, brought him to such a tree. That's what we say. You don't keep Boston and come here. That's it.
Yeah.
Yeah.
Sam, this is what rest on the pen.
I don't know.
I was a director of the nice rock star. So
Nice. We're excited to be here. Stay tuned.
They do move up.
Yeah.
towards, quality, safety and.
Perfect.
And improving things at the hospital system level, so he's.
Yeah.
Doing better. So,
Cardiac anesthesiology, and definitely want to get on board with the bone improvement you guys are after.
we speak a lot of the cardiac surgery patients. Yes.
Right, yeah. So I took a tour yesterday of the unit, and obviously a growing portion of it.
Yeah, they grow a lot last year, Europe too.
Yeah, so I'm happy to be.
Yeah, see, I had 0.8 surgeon, now we have 5.
Right. That'd be great.
All right, let's.
But then I might have to run.
Yeah, All right, guys, we'll go ahead and get started. So today we have Dr. Govind Rangrass. For those of you who don't know him, he's one of our transplant anesthesiologists here at SLU Hospital. Dr. Rangrass did his undergrad at Yale and did his medical school at University of Michigan in Ann Arbor, and then did his residency in anesthesiology here at WashU in St. Louis, and did a fellowship in transplant anesthesiology at UCLA. And he is currently an associate professor in the Department of Anesthesiology and Critical Care, and he's the director of transplant anesthesiology and quality and safety in the Department of Anesthesiology. So he's going to be talking to us today about the role of ECMO in transplantation overall. This is a topic that we haven't discussed in our ECMO lecture series so far. So excited for this lecture, and thank you for coming today.
Thanks, Kasant. Oh, okay. Small group, we can keep it informal too. So today I'll be talking about ECMO and transplantation. This has kind of historically been considered a bit of a fringe topic, but became an interest of mine in my previous position where I was at University of Chicago. I spent 4 years on faculty there, and my clinical niche there became anesthesia for simultaneous heart, liver, and heart, liver, kidney transplantation, and also the use of ECMO in liver transplantation. So I'm going to tie in some of those because I think ECMO has a lot of applicability to the combined simultaneous thoracic and abdominal organ transplantation, the innovations that we developed in my previous institution. I have no financial disclosures. And so, I'll start by saying, but with a lot of advancements in science and surgical techniques and perioperative care, our ability to care for an increasingly sick patient population suffering from multiple organ failure, much attention has been placed on how far we can really push the limits of transplant care. And in this talk, I'll again explore it's not my car. I wish it were my car. I drive a minivan, so. Again, she's rubbing it in now, I'm thinking about my Toyota Sienna and how many French fries and breadcrumbs there are in the back. Bet the black Mercedes definitely doesn't have that. All right, so again, this was really what was considered a fringe topic at one point, but now has become more applicable with multivisceral transplantation. Specifically, I will focus on abdominal transplantation and combined abdominal thoracic and the role for ECMO in executing these complex operations. We certainly know cardiovascular etiologies are consistently the leading cause of early mortality and account for about 40% of early deaths following liver transplant. The use of ECMO to treat cardiac and pulmonary failure in liver transplants is uncommon and poorly understood despite the high morbidity and mortality related to these cardiopulmonary complications. And today we'll present a large single center case series of adult liver transplant patients requiring ECMO. Many of these patients I cared for personally and had an opportunity to help design their perioperative care and also have an opportunity to discuss pragmatic approaches for their use of ECMO in potentially reversible cardiopulmonary conditions. So, Mesopotamian populations believed the liver was actually the central organ of the human body. The venue of life, soul, emotions, and intelligence. This was a belief that persisted among the Babylonians as well. The liver was also an important organ recognized by the Egyptians who removed it from the corpse prior to mummifications. But unlike ancient civilizations, Egyptians believed that the heart was the seat of the soul, and therefore they left it inside the body, inside the corpse after mummification, so to guarantee passage to the spirit to the afterlife. Mesopotamian culture also influenced the Greco-Roman world, which supported the idea of hepatocentrism, seen in various writings, such as the famous myth of Prometheus and his immortal liver. Those of you, have you seen this new show, Chaos? It was, I think, on Hulu or something, but that's a scene from Chaos. So actually, a lot of this new show rings true to actual Greek mythology, and so that they show Prometheus with his liver being pecked out by this eagle, but the liver having regenerative properties, he's able to live on forever while this bird feasts on his liver. So if you're familiar with, so that was recognized very early on that, the liver has regenerative properties. I thought it was kind of interesting. So if you're familiar with Greek mythology, you may recall that Theseus was the mythical Athenian king and hero who slayed the Minotaur of Crete. And the Athenians kept the ship that had brought Theseus back from Crete in the harbor as a memorial to their greatest Athenian hero. But after a while, that the sail became torn and the oars and planks became rotten. And these parts all eventually had to be replaced until pretty much every component of the ship had been replaced. So was this still the ship of Theseus? It was discussed at length by many philosophers. Heraclitus maintained that it was not the same ship, and his answer gave rise to the famous saying, "One cannot step into the same river twice, for it's not the same river and he's not the same man," meaning that that you nor I are the same person or same composition as we were yesterday. But Aristotle thought that this was actually the same ship, as it had only been infected by insubstantial changes. And in his analysis, he distinguished between between accidental and essential features of objects. So what does it matter if the accidental features like planks and oars are changed? The essential feature, that of the ship being able to sail, is still intact. So it's interesting. I bring that up because it's interesting to imagine how the ancients, who saw organs as seats of the soul, would perceive modern day transplantation, with our ability to transplant isolated parts of the human body, such as bones and soft tissue grafts, to organs vital to systemic function in life. I think most of us would agree that on some of the obvious limitations of pondering the ship of Theseus paradox in the context of organ transplantation, but we should recognize undergoing organ transplantation is in many ways an extreme experience, that the body is indeed far more than just spare parts, and that our technical ability to execute complex organ transplantation has evolved to now use more advanced techniques such as mechanical support. Speaking of which, combined abdominal and thoracic transplantation has really grown over the significantly over the past couple of decades. Over half of all the combined heart, liver, and liver lung transplants ever done in the United States were done in the last 7 years. Similar growth has been seen in Europe. Combined heart, liver, kidney transplants have seen dramatic increases in number, although they remain relatively infrequent and high and concentrated at just a few higher volume transplant centers. And these are really highly complex operations requiring a lot of coordination of resources and care. Simultaneous heart, liver, kidney transplants are commonly done for patients presenting with heart failure or ischemic heart disease presenting with liver and kidney failure. These can include high MELD patients who also have ischemic cardiomyopathy or chronic kidney disease, or low MELD patients who may have cardiac cirrhosis from congestive hepatopathy. Another indication for combined heart liver transplantation is non-ischemic cardiomyopathy, such as amyloidosis and hypercholesterolemia. And these are, again, becoming more and more common, with over 60 of these cases of heart, liver, kidneys done worldwide to date. This is a recently published article that shows the growth of combined heart liver transplants with rapid year-over-year increase. And, we can observe an evolution in the indications for performing these combined cases. Some of these centers that do these cases or really specialize in patients with metabolic disorders like amyloidosis, and others are increasingly performing combined procedures with liver transplant patients who have congenital heart disease, which is now the #1 indication for combined heart liver transplant. And an increasing number of operations are also being performed for unrelated organ failure in patients who otherwise would not be a candidate for any single organ transplant alone. So in addition to that, simultaneous cardiac surgery plus liver transplant is showing promise over sequential surgery by decreasing overall morbidity mortality. So in the past, you'd have a patient who has a cardiac problem who'd come in for evaluation, but they would find the patient is a cirrhotic. The question became, is this patient really a surgical candidate? We know that cirrhotic patients do really, really poorly when undergoing cardiac surgery and prolonged bypass times. So now we have the ability to do combined simultaneous cardiac surgery and liver transplant. So, historically, there was some debate about whether these types of cases should be done at the same time or sequentially. And, going forward, it'll be important to look at outcomes, such as a study that looked at this. The N was pretty small here, but they queried the UNOS database for sequential versus simultaneous heart liver transplant and cardiac surgery liver transplant. I will point out before getting into the meat of the talk that the liver allograft has been observed as early as the 1960s to be very tolerant to alloimmune injury. So unlike other organs, liver transplant recipients are often maintain a much lower pharmacologic doses of immunosuppression than recipients of other organs. And that suggests that the liver allograft can provide immunoprotection for simultaneously transplanted organs. So when we do have the opportunity, simultaneously transplanting a kidney with the liver at the same time, or a liver with the heart, can confer some protection and help clear donor-specific antibodies. And a few small studies have demonstrated that there's a significant reduction in a heart allograft rejection. We see similar results in the kidneys. And this is some of the data, just for your reference. You can always look at it later. This looks at T-cell mediated and antibody mediated rejection. And so this shows really good survival of patients undergoing combined heart liver transplantation. Now the question now subsequently becomes, how do we continue getting patients through these complex surgeries, and which brings us to, where does ECMO come in? And so today we'll talk about the use of ECMO in executing these very difficult combined cardiothoracic liver transplant cases. We'll talk about, in liver transplantation alone, how the use of ECMO can help with reperfusion syndrome and can confer protection to the newly transplanted heart, and also some considerations for surgical techniques that are used, and why we may want to use ECMO or other forms of mechanical support. Now, going just briefly back to heart liver transplant, this is a picture of a on-block transplant. So, this wasn't really, I've never actually seen this done, but this is where the heart and liver are transplanted at the same time, and they're connected. So and the whole case is performed on full cardiopulmonary bypass, so the cava remains intact. But what is more commonly done is, when we do these multiple organ transplants, that we start off first with a heart transplant, then move on to a separate phase where there's a separate incision for the liver, and then after that, the kidney. And this picture shows a liver transplant being performed on via ECMO after the heart transplant was already completed via a separate sternotomy incision. And for those of you who are less familiar, and this is a gross simplification of the surgical technique, but the liver, when we transplant it, it's really important for you to understand this anatomy to understand why we would need mechanical circulatory support in certain situations. But it's commonly done in either one of two ways. Again, a gross oversimplification, but the liver can either be sewn in anatomically, where you resect the recipient cava, and you sew the donor liver in exactly the way it was sitting in the recipient originally, and or you can actually do a caval preservation technique, where the liver is the cava of the liver is sewn to the cava of the recipient, and so just looking at this, when we actually do this operation, can anyone kind of guess which one might be hemodynamically less favorable? Probably the first one, right? Because here you're actually occluding the whole cava in order to sew it in. You also have to do two separate anastomoses, so the warm ischemia time on the liver is going to be longer. When you occlude the whole cava, now you're suddenly obstructing blood flow from below the diaphragm back to the heart, right? And not counting some of the collateral circulation. So that's one of the major challenges we encounter as anesthesiologists caring for liver transplantation is the complete cable occlusion. Now add in the patients being really, really sick coming into the case, being on multiple pressors or being a high MELD patient, or maybe having lots of bad portal hypertension and then bleeding significantly. You can imagine the volume, the complications that may present with volume management during the actual transplant. So what we can commonly do here is the use of vena-venous bypass. And this was a technique invented right from the beginning when liver transplantation was first started, where it's actually very similar to an ECMO pump, right? So you have a femoral cannula that drains and takes blood to the pump, and then the blood is pumped back to above the diaphragm. Sometimes you can add in add in a portal vein cannula, but the cannula returning blood to above the diaphragm can go in either through the axillary vein, a subclavian vein cut down, or what we commonly do here at our institution is actually a percutaneous large cannula in the IJ. And when we say large, it's not as large as your traditional ECMO cannulas. We're talking about 50 and 17 French cannulas because we only need to really support a blood flow of about 2 liters. And Dr. Nazal is in the audience, but he introduced us to our ability to be able to even do this through regular cortices to provide, the hemodynamic stability sometimes that we may need from even just about 1 liter of flow when we're doing this on bypass. So that helps the patient tolerate cable occlusion when the liver is being transplanted during the anhepatic phase. All right, so when it comes time to when we're doing a heart liver combined case, actually this technique, it sounds kind of simple. You may, when I describe it to you, you kind of like, duh, like this seems like a straightforward way to do it. But we actually innovated this technique, right? So, instead of doing the heart liver transplant on block, we first started with the heart, and so that's done on full cardiopulmonary bypass. And for cardiopulmonary bypass, there's an SVC cannula, and then there's also your aortic bypass cannula. But so once they're done reperfusing the heart, then what we can actually do when we move on to the liver transplant part of the operation is we can actually repurpose those cannulas and actually use them we can use them as the SVC cannula as a drainage cannula and the aortic bypass cannula as a return, and so we can help maintain hemodynamic stability this way. We can also drain blood through the femoral vein cannula and almost use it as a vena-venous bypass circuit by bringing that blood, diverting that from below the diaphragm all the way and bring it back up after it's been oxygenated. So then we can proceed with liver transplant operation without having many of the effects of volume overload after clamping the cava. We don't then necessarily have to subject the new heart to a massive amount of volume, and then by doing it this way, we can actually reperfuse the liver on VA ECMO and help reduce the reperfusion injury to the cardiopulmonary to the new heart and cardiopulmonary system. Did everyone know what reperfusion syndrome is? So that's the other part of liver transplantation that we get really worried about is when we have a highly metabolic organ that then we go ahead and reperfuse. The liver may have sustained a prolonged period of cold ischemia time. Now you're adding in warm ischemia time while it's actually being sewn in. If you're doing a heart transplant before the liver transplant, guess what? That cold ischemia time, you're really pushing it to the limits. So this technique conferred a lot of significant advantages because when we do reperfuse the liver, you suddenly release all those toxic metabolic byproducts, lactate, potassium, cold preservation, all straight into the cardiopulmonary system. And there's a triad of reperfusion syndrome that is hypotension, bradycardia, and pulmonary hypertension. So you can imagine those 3 things together during the time of reperfusion are really, really bad. We won't get into normothermic reperfusion, some of the new innovations in pumped livers, but that's certainly made a significant improvement. So, with our increasing use of mechanical support, we've seen, significant improvements of in outcomes and despite historically acceptable outcomes across a wide range of simultaneous abdominal thoracic transplantation operations. And there were here 11 consecutive simultaneous heart, liver, kidney transplants that we did over the course of 3 years at University of Chicago with 100% 1-year survival. And when we applied this also to orthotopic liver transplant at the time of open heart cardiac surgery, again, these outcomes are quite acceptable. This approach, doing it simultaneously, is preferable to stage procedures, and especially with patients with advanced liver disease. And this really comes into play when we're in our patient selection meetings, and with looking specifically at the potential reversibility of conditions such as pulmonary hypertension, congestion, and myocardial dysfunction. So, in order to attenuate the risk, we try to do this without, putting every patient on ECMO. So some approaches that we've come up with in recent years for patients who are getting both simultaneous liver transplant surgery and cardiac surgery is to perhaps consider performing coronary bypass grafting without cardiopulmonary bypass. For patients who need aortic valve replacement, bioprosthetic valves allow the avoidance of anticoagulation, and some advancements in minimally invasive TAVR. A lot of patients may be bridged successfully to transplantation with low morbidity. But for any liver transplant patient combined with cardiothoracic surgery requiring cardiopulmonary bypass, we've certainly seen a significant benefit to attenuating reperfusion injury to the heart after bypass runs by using ECMO intraoperatively, and with an assessment of the heart function, the option to continue and repurpose the cannulas for postoperative ECMO use for prolonged weans if there's continued cardiac dysfunction. After a typical heart transplant or open heart surgery, for that matter, that is reperfused on cardiopulmonary bypass, the patient often has days to recover in the ICU. And so again, consider for a moment that when we're simultaneously transplanting a liver, we're taking, again, that freshly transplanted heart or a heart that had been arrested for bypass grafting or valve replacement, and now subjecting it to the significant reperfusion insult. And our biggest perioperative concern always remains right heart function, maintaining its intact function, avoid precipitating right heart failure, which with the use of VA ECMO in those limited cases has had favorable results. So time. And again, these can be done without mechanical support and also with veno-venous bypass. So the centers that are now getting more experience with this you tend to see a shift to an all or nothing type of approach. And so even in the liver transplant world, there are some centers, high volume centers, that they do every single case on veno-venous bypass. So University of Pennsylvania, there's not a single liver transplant that they do that is not on veno-venous bypass. I was quite intrigued to hear that. And so certainly with a center that is doing just a small handful of combined heart, liver, kidney, or heart, liver operations, if you develop a system to do it and you do it the same way every time, you're probably going to have better results. So the operative events are as follows. The sternotomy is first made, the heart transplant occurs, and the patient's then weaned off of cardiopulmonary bypass, fully reversed, and then the SVC and aortic bypass cannulas are left in place and repurposed for a VA ECMO. The SVC cannula serves as the drainage cannula, bringing blood into the oxygenator, and the aortic bypass cannula is the return cannula. The abdominal dissection begins, And during the anhepatic stage after the cross clamp, there's careful monitoring of the heart with TEE, which helps inform the adjustment of ECMO flows to maintain cardiac filling with the opening of the aortic valve and also arterial pulsatility, while offloading the heart to avoid congestion and maintain an adequate map. After hemostasis is achieved, a decision is then made to wean via ECMO is made, and if ECMO successfully weaned, the abdomen and chest are closed, and decisions made to whether to proceed with a kidney transplant. So I would add that our early experiences with this suggest that we would need additional femoral venous cannula for additional flow because if you're placing a cross clamp on the IVC, then having just flow from above going through the ECMO circuit may not really help you as much and may require you to give a large amount of volume. So this is a picture of the operating, and there's lots of people here, perfusionists, anesthesiologists, multiple anesthesia teams, and multiple surgical teams. And we talked about the setup here. All right, so moving on to liver transplantation. Two main uses for ECMO and liver transplantation are, one is a planned bridge to transplantation, and then the second is for postoperative rescue. And over my time in my previous position, we had 11 patients who underwent liver transplantation that required ECMO, and 4 were planned. 2 we use intraoperatively as a rescue, and again 5 postoperatively were used as a rescue. I'll just report a few of the outcomes. If you're really interested in this, I have here a QR code for a table. This lecture is recorded, so you can always go back, but I won't go through this table in detail, but we looked at a lot of different factors. With a limited study like this, case series, you're not going to find any real trends because all the patients were so different. So the reasons for ECMO initiation were as follows. So I think the most interesting use case scenario for ECMO is when you're planning right up front to use it, not necessarily as much as a rescue. And I will talk about why. But I'd say the number one use case scenario for the use of planned ECMO as a bridge to transplantation is patients presenting with severe hepatopulmonary syndrome. And one of the first few patients we use as a planned bridge to OLT was a patient with a PaO2 of 52. And we'll talk a little bit about HPS and what that is, and I have a little video for you. But that counts as in the severe to very severe range of hepatopulmonary syndrome, where patients have baseline hypoxia. They look pretty good, but they require oxygen to move around. But are they going to really tolerate large volume resuscitation? Are they going to be able to withstand a major postoperative complication? Other patient that actually did quite well is patient with severe RV dysfunction secondary to volume overload. And in fact, interestingly enough, while we use those 2 indications in my previous position, here in the last 2 years, we actually used VV ECMO as a bridge to transplant for very similar cases. And we'll talk about that patient. We had one HPS that was in the very severe range, and another patient who had significant volume overload and with hypoxia. And so I think it's important to note that neither of those patients had intrinsically high pulmonary hypertension or severe pulmonary hypertension, which would actually be an independent reason to say maybe this patient is not a liver transplant candidate. Okay, so it's an important thing to exclude. We'd use it as a planned bridge for patients getting cardiac surgery as well as liver transplant. And then for rescue purposes, we talk about the main issues that we worry about: arrest from reperfusion syndrome, hypoxia at the conclusion of the case. During COVID, patients had hospital-acquired pneumonias and severe RV dysfunction in the setting of multi-organ dysfunction with infection, and then I think some of the other rescue reasons, are slightly debatable. But with the patient who had hyperkalemic cardiac arrest, some of the issues that can pop up is post-operative primary non-function of the transplanted liver. So when your liver either is rejected or doesn't take, or there's a major complication post-operatively with hepatic artery thrombosis, where the liver is dysfunctional and the patient ends up on rocket fuel, This ECMO can serve as a rescue temporizing measure, but ultimately the patient probably will need retransplantation as definitive therapy. So our first patient with severe HPS, we initiated the planned use of vena-venous ECMO via the peripheral, femoral, and IJ vena-venous cannulation. This patient had actually normal heart function, and you have to take great care to de-air the circuit, given the pre-existing right-to-left shunting. We'll talk a little bit about HPS. I have a few slides on that. And this patient actually had significant blood loss intraoperatively, but was extubated on post-op day 1, remained on ECMO for about 8 days. And there's a reason for that. So the ECMO is not just to get the patient through the time of surgery, but is also to help provide oxygenation support for many days, even potentially for weeks after a transplant for a patient with hepatopulmonary syndrome, because their underlying pathology is vasodilation in their lungs, causing blood to not participate in oxygen exchange, and it takes time for those shunts to close. And I'll tell you exactly what the pathophysiology is in a few minutes. So you can look at this circuit resembles very much a vena-venous bypass circuit. But if you look here, if we put the same circuit in for a liver transplant, the way this picture is shown, can you tell me what the problem might be? What's wrong with the position of the cannula? It's all the way up, right? So if you clamp over that, I've seen this happen. You clamp over that and you do a cavotomy where you make an incision over that clamp, you're going to entrain air into the circuit. And this happened. I witnessed this happen in a case. It was unintentional. The cardiac surgeon placed the ECMO cannulas. The liver surgeons should have placed the ECMO cannulas, because down below where they're used to doing this with vena-venous bypass, so they should know that can't go that far. And it was move. Heart's already been transplanted. Now move on to the liver, clamp over the cava. Cavotomy is made, massive error in training the circuit, everything shut down, right? That was a total disaster. So the tip of the drainage or inflow cannula should be placed in the infrahepatic vena cava, and checking this is very important. And again, we saw that complication. This just kind of shows you the anatomy here, right? You got what the blood flow into the liver. Most of the blood flows through your portal vein. Then you have hepatic arteries, gives about 25% of the blood flow. Then the blood flow out of the liver comes out through the hepatic veins into the IVC. So, well, the abdomen's open, you can actually palpate it, but they should have been palpating it, right? They should have been able to feel it. But you can just do it under fluoro. You can call for fluoro to do it. In fact, that's what we did for our case here, the one that you and I took care of. We had those cannulas placed under fluoroscopy in the cath lab, and I thought that was the best way to do it, as opposed to going in blind and guessing later on and risking this type of an issue. So in contrast to peripheral VV ECMO, our second patient was placed on peripheral veno-arterial ECMO, which is seen here on the right, where the drainage cannula remains in the femoral vein, but the return cannula is placed in the femoral artery. This second patient had a sadder story. She was a 44-year-old with NASH cirrhosis and MELD 33, had preoperative AKI, relatively straightforward intraoperative course, but had a hyperkalemic arrest in the ICU. She was cannulated for VA ECMO. We returned to the OR, discovered ABGs drawn from the right hand showed a low PaO2 of approximately 50, despite a really good saturation on the left forefinger. Anyone know why that happens? You've heard about this. This is dual circulation, right? North-south syndrome. This occurs on VA ECMO when draining deoxygenated blood from the IVC and reinfusing oxygenated blood into the femoral artery, all while there's pulmonary blood flow without any oxygenation by the lungs. So deoxygenated blood from the SVC enters the RV, and pulmonary artery, without getting oxygenated by the lungs, goes to the left side of the heart and is ejected into the proximal aorta and cerebral arteries. And so this can cause critical cerebral hypoxia. This prompted us in the moment when we recognized this to place the third cannula in the right IJ to bring oxygenated blood back to the heart. And given access issues for initiating hemodialysis, we were actually able to dialyze through the ECMO circuit. And Thankfully, this patient had actually a normal neuro exam post-op day 1, but complicated post-operative course, ultimately died. This was another patient, really interesting use, and we actually borrowed from this when doing our case here at SLU. This patient was a 52-year-old with a MELD 40, ETOH cirrhosis. He had hepatorenal syndrome and really severe right heart dysfunction from volume overload with a PVR of 0.9 Wood units, so normal on CRT. So prior to proceeding with liver transplant, we, since he had right heart dysfunction, it was purely from volume overload, but this was this guy's window. Like we weren't going to sit there and diurese this guy more. He was already on some pressors. So, this was his window. He got an offer. He was a rare blood type. We said, hey, how do we get this guy through this case with his right heart dysfunction? So we placed a percutaneous RVAD with an oxygenator via dual lumen cannula placed in the internal jugular so that its drainage or the inflow lumen is located in the SVC and the return or outflow lumen is in the pulmonary artery. So it basically bypasses the right ventricle. We inserted a femoral vein drainage cannula, which effectively turned our circuit into a vena-venous bypass circuit and provided really favorable conditions for the patient to be able to tolerate a full cable clamp, since that was the anatomically recommended method to do his liver transplant. This patient did really well. So just a few like little stats here. Those patients that at least I've taken care of myself, and that N is again very low. But when my takeaways from these cases that I've been involved in is when we plan and we bridge these patients, and this is part of a planned approach to transplant, it sets patients up for successful outcomes. And when we're also using ECMO to help treat reversible causes of hypoxemia, patients also do well. You can see the table as well if you're interested in doing a research project on this or doing a review. I'm right now I'm the PI for the Society for the Advancement of Transplant Anesthesia multi-center ECMO and liver transplant study that we're doing, which will be the largest multi-center study on this particular topic. And we're doing it with UCSF, University of Washington, University of Michigan, and a few other large academic transplant centers that are part of the Society for the Advancement of Transplant Anesthesia liver quality database group. So, all right. So I promised you a little lesson about hepatopulmonary syndrome. So the patient we had here, I think it's really interesting to read about or to learn about. You may have read about it in the news, or we actually have a case report. So if you really want to learn about all the nitty-gritty details, you can look this up. This was a 66-year-old man with very severe HPS. His PaO2 was 45 on room air, and he required 15 liters of oxygen on a non-rebreather at home. So can you imagine what this guy's quality of life was? Like, I saw him the day when he came in for his transplant. He was in the bathroom showering, and he's oxygen on in the shower, right? And he had cryptogenic cirrhosis, and he came in for evaluation. And so we put a lot of effort into figuring out are we even going to do this case? Because across the street they said no. And so we did. Part of the evaluation includes a TEE with a bubble study, and so he had a large extracardiac shunt. I'll show you a picture of that or a video of that. And what we see in these patients is a large amount of bubbles that when we do an agitated bubble study, you inject bubbles into the right heart. And if you have a PFO, you typically see those bubbles come into the left heart within 1 to 3 cardiac cycles. But if you have extra cardiac shunting or pulmonary vasodilation resulting in shunting, those bubbles will have delayed entry into the left heart. So you normally don't expect to see any bubbles at all, right? But if you have that extra cardiac shunt, you have delayed entry of those bubbles between 3 to 6 cardiac cycles. And and so HPS, this guy definitely is in the very severe category. So you commonly see the definition of HPS: patients with cirrhosis and portal hypertension with reduced arterial oxygen saturation. Like, why does this occur? Well, it occurs because when you have cirrhosis in your liver, you have elevated levels of circulating nitric oxide so you have splanchnic vasodilation, and that nitric oxide elevated levels can cause vasodilation. In some patients causes pulmonary vasodilation, and those are when the shunts are created there, you have right to left shunting, and blood that goes through those shunts does not participate in oxygen exchange. So then subsequently you have reduced arterial oxygenation. And here's let me see if hopefully this video works. So here you see on the right side of the screen, on the left side of the screen is the right heart. We inject some bubbles. Here we expect to see the bubbles come here. I may have cut off the video here, but you see that the bubbles disappear here, and then they appear here probably about 4 or 5 cycles after. So that's pretty typical for that's what you'd see in hepatopulmonary shunting. You see the bubbles appear here in the left heart. That was the patient's actual echo. So again, he's in the very severe category. This is a picture of what the pathophysiology of HPS looks like. We talked about elevated levels of nitric oxide, and they not only cause vasodilation, but also increase VEGF production, leading to angiogenesis. And so effectively with this dilated capillaries and angiogenesis, this is all blood that should have been oxygenated, but now is not. In portal pulmonary hypertension, a little bit different. Here you get sclerosis and vascular and vasoconstriction and kind of smooth muscle endothelial proliferation with platelet aggregation. Clinically, HPS is really interesting because you think about patients with cardiopulmonary issues. If they lay down flat, you think that they would have worsening symptoms, but actually they're actually better when they lay down flat. The dyspnea worsens when they go from a supine to an upright position, and that's due to the vasodilation being most severe at the lung basis. So for our patient that came in for surgery, the surgical plan was a full cable replacement. We weren't going to be able to do this as a piggyback technique where it was going to be cable sparing, where we still have blood flow through the inferior cava. We're going to have to give this patient a large amount of volume for him to be able to compensate. And in addition, they planned for a portal vein thrombectomy, so the patient actually had a portal vein thrombus. So the implication of that is if there's a thrombus here in the portal vein, then when they go and when we make it when we ligate this, before we sew it back into the new liver, then this thrombus has to be cleared out. And they clear it out basically like what the plumbers use, like roto-rooters. But in order to make sure that it's patent, you have to let it bleed. So you lose like a liter of blood just by making sure that, hey, is this patent enough? Is there enough flow coming out of this before I go ahead and I suture this portal vein and then reperfuse the liver? Not to mention, we're going to deal with, since we're doing a bicaval approach, this is going to involve 2 anastomoses instead of just 1. And so the potential for greater hemodynamic instability and increased bacterial translocation, the portal vein thrombectomy, we kind of say, this guy's baseline hypoxia, he's not going to just tolerate this as a straightforward case. Even if we do pump this liver, now you throw in reperfusion syndrome, this patient may not do well. Even if we get him out of the operating room, how is he going to do in the post-operative period? So we decided to go ahead and preemptively place him on VV ECMO, which we did with the help of our cardiology colleagues, and we also placed a femoral bypass cannula. So it was, and the exact device we used was the Protect Duo device. Are you guys familiar with what that is? Okay, so the Protect Duo is kind of similar to the third patient we talked about. It's 1 cannula, but it's got 2 lumens. And so the distal end of that lumen, the distal end of the cannula is in the pulmonary artery, proximal is in the RA or SVC. And so we're bypassing the right ventricle, and we're now able to provide oxygenated blood. We're able to take away this whole issue of hypoxia intraoperatively or resulting from postoperative complications or large volume resuscitation. And we can take all of that out of the equation. And it's especially helpful when we have a good, highly functioning heart. Now we add in a femoral bypass cannula, and that way we don't have, we have a way now to do this on venous bypass with a total caval occlusion. We're able to take blood from the bottom and bring it back to the top. It kind of looked a little bit like this, what we showed you, but with an oxygenator. And, we commonly use venous bypass for other reasons. In the past, it was used to be a bit of a game time decision. The surgeons would do a test clamp, but that approach hasn't been shown to affect outcomes. Better just to have a plan in place going in, have an understanding of how does the patient's heart function, what is the volume status like, what kind of pressures and how sick are they, what does the anatomy look like, is there going to be a lot of bleeding, and 99.9% of the time we are able to tell you this patient will need venous bypass or not. So intraoperatively, the patient did receive quite a large amount of blood products, and then postoperatively had a massive complication with an arterial bleed. Is that right? And with like 3 or 4 liters in the abdomen. So there's no way that, and the way that we ended up configuring this patient, was exactly what I just mentioned. Was we had, you have the upper body, lower body, the right femoral vein cannula, your right atrium, and that's your drainage that's going into the pump and oxygenator, coming back into the pulmonary artery, right? So, it effectively served as a right ventricular assist device. And at the end of the case, we were able to decannulate the femoral, because we were just using that to do the liver transplant to help tolerate the caval clamp. So that cannula was decannulated, and then the patient was then recovered in the ICU, where he had the bleed was taken back to the operating room. We left the Protect Duo device in place because we knew that it's going to take time for these shunts to close off. The only known treatment and cure for hepatopulmonary syndrome is a liver transplant. And so patients with HPS can take weeks to even months for these shunts to close off afterwards. And so we knew that was why we left the patient on venous ECMO. And the patient was then met our weaning protocol over several days. I think it was probably about 10 or 11 days here. A tracheostomy was prophylactically performed on the patient, and then ECMO was decannulated on postoperative day 11. And I think Ghassan can tell us, how do you think this patient may have done if we had not had this technology, had this patient done it this way? Probably not well. Post-op, especially with the complication. So this patient did pretty well. He was discharged after about a month in the hospital to an LTAC. He had a very long postoperative course. I will say there was something really interesting that happened. Okay, so when he closed off his shunts, his preoperative TTE showed this very small, trivial PFO. It was something that we didn't feel very strongly about doing because it was like a possible small, trivial PFO. Well, when he closed off his pulmonary shunts, what happened? What do you think happened to his right-sided pressures in his heart? Went up, right? So when his right-sided pressures in the heart went up, he blew up in his PFO. This patient's been in the hospital for a long time. He's not been very ambulatory. He's probably got high DVT risk. Now, boom, he embolizes a clot, goes straight through this PFO, causes a stroke and a massive PE. Okay, but but he recovered from this. Okay, so this is kind of a big learning lesson when we did this case was if there's any question with a PFO in a patient with hepatopulmonary syndrome, we should address that before proceeding, or at least have some surveillance afterwards of hey, while these shunts are closing off, if his hypoxia is getting better, his right-sided pressures are probably getting higher. Is that PFO getting worse? Does he need to be surveilled for DVTs? Does he need anticoagulation for any purposes? Does he need any prophylactic closure of this PFO? Yeah.
You got readmitted. Yeah, 5 weeks after transplant.
Yeah. Here you can see this is the PFO.
We did an EE and we saw the bubbles come through pulmonary veins, so it was more of a extra cardiac, more significant. So we thought the PFO was small, it's there, but not contributing much.
Exactly. And so we actually put these pictures of this is from pre. So there's a little tiny bubble. Maybe you're like, oh, is that the extra cardiac shunt? And then here is where he blew it open. And here's his MCA stroke. But he recovered. I have just like a few minutes left. So I'd just conclude by saying, in the talk, we discussed how ECMO can be used as a bridge to transplantation for intraoperative rescue in the postoperative setting to provide mechanical support when medical management options for severe cardiopulmonary failure have been exhausted. But I think the takeaways are prior to using ECMO as a bridge to transplantation, you really have to focus on post-transplant reversibility of these conditions. So this is our patient here at SLU, right? So this was written about a little bit in the news. And I'd conclude by saying, as we continue to push the envelope and execute these really complex operations on and replace the human body's failing parts, our thoughts may go back to and consider again the ship of Theseus I brought up at the beginning of the talk, not as a thing, not even as a collection of replaceable components, but really as an entity with a living history that has perceptual continuity. And when Theseus thinks of his ship, he has expectations about what parts can be found where, the tools that it took to put them together, how they interact with each other, and how they interact with the rest of the world. And as long as there's a time and space continuity between the set of relationships, it's still the ship of Theseus. And so no matter how we seem to kind of put the human body's failing parts back together, there appears to be synergism and interdependence, and we'll continue to study this for many, many years. But obviously the body is that of our patients, but our patients go a really major transformation when they go through transplantation. And that's defined really by a long road of healing that was made possible by the gift of their donors. So this was the first back-to-back triple organ transplants that I got to be part of. I'm in this little picture over here. That was my claim to fame for my 4 years there. And these two patients, they were both 29, and they, it was out of these cases we innovated using ECMO and combined heart, liver, kidney transplantation. And we did these cases back to back. So we were in the hospital pretty much all weekend. And these two became friends. They recovered in the ICU afterwards. So it was kind of really nice, heartwarming story of patients who did well, and then also allowed us to, really help make some innovations in how we do these cases, and went on to do them with really successful outcomes and 9 more patients afterwards. So, all right, thank you for your attention. Any questions? Yeah, cool.
With pulmonary hypertension patients, because we see them pre-op and pulmonary hypertension, portopulmonary hypertension. We know that mean PA pressure about 35, they have much worse outcome. They're excluded, but the our teaching was treat them with vasodilators. If you can drop the pressures, they can still go. Is there a role for ECMO in those patients? But the issue with pulmonary hypertension, it takes much longer to, even after transplant, even treat them with vasodilators. They remain on vasodilators for up to a year to
Yeah. Yeah.
start making those reverse the changes in the pulmonary artery. So
Yeah, most of the literature on pulmonary hypertension and liver transplant has been written in the early 2000s by Krakow, Krakow, and he's come up with various criteria that would be exclusionary criteria. Now, since the early 2000s, we've kind of moved beyond thinking of absolute numbers of, you know, their pulmonary pressures are X, Y, and Z. Really think about, you know, is it portal pulmonary hypertension reversible? Right. So if this is just due to the liver, then we put the liver in, then this should get better over time. But they have intrinsic pulmonary hypertension, then we evaluate that with a right heart cath, and we figure out what is their transpulmonary gradient. And when we divide that by our cardiac output, what is their pulmonary vascular resistance? And that's something that doesn't really improve much over time, right? So if we see volume overload related issues or portopulmonary hypertension, you'll see pressures elevated on both sides. So I really dig it. And instead of just looking at absolute numbers of PA pressure over 35, we try to think about it as, okay, what is their wedge? What is their PVR? You know, how is this going to affect our right heart as well? So we then look at our, with this high blood pressure, high PA pressure, do they have RV dysfunction? If they have RV dysfunction, is this going to be something that is then later on reversible? Is it going to get better? Is this RV dysfunction bad enough that we're going to need ECMO to bridge through transplant, like we did with two of these patients that we brought up, where we have the ability to provide some RV support. But if that RV dysfunction is permanent, or that the intrinsic pulmonary hypertension is going to present an RV afterload issue, now you're thinking, okay, later on, this patient may have right heart failure, and they're going to have congestion of their liver, and their graft is not going to work well. So are they a good candidate, period?
thank you very much, Govind.
Thanks.
Thanks, man.
So that was all recorded.